May is Women's Health Month, and we have a special show specifically for our female viewers today. Joining me will be 4 Catholic health experts in different fields, ranging from cardiology and breast surgery to gynecology and primary care. They will share their insights on the specific challenges women face with their healthcare needs, as well as personal suggestions and advice you can start using today to get your health trending in the right direction. That is all coming up today on Stronger Together with Dr. Dave. Hello and welcome to Catholic Health Stronger Together with Dr. Dave. Today we're talking about women's health, and I'm very excited for our first guest. Dr. Rita Germain is a Catholic health cardiologist at St. Francis Hospital and Heart Center. So let's get started. So is heart disease the same in women as in men? We always hear women are not just little men.
That's right, Dave. So there's a couple of different reasons why it is different. So we know that the way that women present, the way that the structures of their heart are, so the size of their chambers, the size of their vessels, the actual capacity of their blood volume is very different between men and women. And most importantly, their risk factors. So we know that estrogen is very protective, cardioprotective, and so when women reach menopause, they often lose that cardioprotective effect. And so the incidence of having coronary artery disease is about 10 years different between men and women. So men will typically present with a heart attack in age 60s and women in age 70s.
Interesting.
And how they present is often different, right? We think about men as presenting with typical angina, where they'll have chest pain, they'll present to the ER with crushing pain in their chest. And women may present with non-specific symptoms. They may feel short of breath, they may have palpitations, they may have atypical angina, they may have GI symptoms, and oftentimes they'll suppress coming to an emergency room or seeing their physician because of emotional reasons or just feeling that their symptoms are due to something else. And so oftentimes they'll present later and they'll present in a more serious condition because they ignore the initial traditional symptoms that we think about.
What are some symptoms that are not the typical symptoms that we could teach them?
Absolutely. So palpitations are really important, feeling extra beats in your chest, feeling short of breath when doing things, feeling like your exercise tolerance is less than it has been before, feeling like you have back pain or shoulder pain that's persistent and especially worse with activity, or feeling indigestion when you're doing things. You know, we think about angina as being stable or unstable angina, and stable angina basically means that you're having symptoms when you do things. Unstable angina means that you're having symptoms even at rest or doing less. So if you're noticing over the last couple days or weeks that at first you were having these atypical symptoms when doing things and now you're getting them more frequently at rest, definitely see your cardiologist.
Right, that's a good point. And you know, something I always tell my patients, if you have a symptom that keeps coming back and it's being associated with other symptoms, you need to get checked. You can't blow it off.
I always said a diary is so important for thinking about a recall of your last week of activity. That really helps to put it in perspective. Because sometimes these people will have symptoms for weeks before presenting.
Yeah, and a lot of times the medical establishment will kind of dismiss the women's symptoms as, you know, perimenopausal or anxiety. I think they have to advocate for themselves. How do you feel about that?
I think it's a great point, and you have to look at yourself, right? So if you're somebody who now is menopausal and you're noticing, I've slowed down my activity, I've put on 15 pounds, my sleep is interrupted, I'm taking care of 5 other people around me, right? Because that's the most common reason is that these women are caretakers, right? By definition, they're caretakers for others. And so they ignore sometimes their own symptoms. So if you're noticing that all of these risk factors are culminating, it's time to really pursue somebody that's going to listen to your symptoms and work them up.
Right, absolutely. And also, don't just blame it on perimenopause.
Never.
Right? Never blame it on perimenopause.
Because remember, menopause is a risk factor for coronary disease.
That's right. That's exactly right. When should we start thinking about screening women?
I think about age 40, but at the same time, I think it's all across the board, right? We're seeing metabolic syndrome and obesity are so much more endemic in our society, and those are big risk factors, right? We're seeing family history at an earlier age. We're seeing men and women with MIs in their 30s. So I can't really put a number on when to start screening, but you have to look at yourself as an individual. and definitely look at your risk factors. And so one of the major ones, like we talked about, is high blood pressure, diabetes, glucose intolerance, obesity. Those are the things that really have to be paid attention to decide when it's appropriate to see a doctor. And at all points in life, you should really be seeing a primary care doctor, right? But the question is when to see a cardiologist. And I think there's nothing wrong with getting a baseline EKG by your primary care, assessing for those risk factors, looking at your ACHD risk factors, and then deciding to see a cardiologist.
Right, and taking into consideration, family history especially.
Absolutely.
And I know you're an advocate of healthy lifestyle. I know that on many different levels. So when you're counseling, you're not your typical doctor or cardiologist. You really do practice what you preach.
Yeah, that's right, Dave.
What do you tell your patients in the 10 to 15 minutes you have with them?
That's a great question. So first of all, I never look at it as a diet, right? A diet is not a solution to metabolic syndrome. A lifestyle change is a solution. So you've probably heard of the Physicians Committee for Responsible Medicine, the PCRM. That's an institution that I'm part of, an institution I truly believe in, and they have physician advocates that speak on behalf of these lifestyle changes. And it's based around a plant-based diet for the most part, but of course they talk about all different things. Athletes that are on plant-based diet, patients with comorbidities that are on plant-based diet, exercise, what's appropriate for patients with heart failure and exercise. And it's a well-respected group that has a ton of literature, both from cardiologists, GI doctors, internal medicine doctors that are all part of this committee. That's a great place to start. And they have an app. Right. And so they also have a lot of book recommendations. So I really start with that. I tell people that let's look at the Physicians Committee for Responsible Medicine. Let's see what they're recommending at this point, and let's start there with how to educate you on lifestyle changes.
Right, and exercise, being active.
So that's always part of it, right? So the minimum recommendation is 30 minutes of aerobic activity. We know aerobic activity is going to be great for dilating the blood vessels, increasing blood flow to the capillary, releasing those endorphins. All those things are the things you want really for heart healthy.
So the message today is women are not the same as men.
They're not little men.
They're not little men. If you are watching this program and you're a female, you need to speak with your primary care physician if you're at the appropriate age or if you have risk factors.
That's right.
To meet with a cardiologist such as yourself and get screened. At least have a conversation. I always tell people it never hurts to speak to people.
Not at all. And be an advocate for yourself. If you don't feel right or something's not right and people are blaming this anxiety, go see somebody else.
100%. Well said. Great point to end this on. And we're definitely going to have you back on the show.
Thanks, Dave.
Coming up next, we'll hear from a breast surgeon about the different types of breast disease and the treatment options available. You're watching Stronger Together with Dr. Dave. Welcome back to Catholic Health Stronger Together with Dr. Dave. We just learned about specific tips and advice for women's heart health. Now we're focusing on breast health with Catholic Health breast surgeon Dr. Marlene Mancuso.
Women really need to understand the changes that may occur in their body and specifically their breasts. First, women need to understand that disease is a change in structure or function that may cause symptoms and may not. But regardless of whether or not there's a symptom such as pain or a lump in the breast or no symptoms such as a tiny finding evident on mammography, most often these changes do not cause harm. And so this is important when it comes to understanding your breasts, that most likely if there is a change or an abnormality, it is likely to be something that is non-cancerous. The most common type of breast disease is benign breast disease that does not confer an increased future risk of breast cancer. I do encourage self-breast examination. This is a monthly examination, so for the entire year, only 12 exams. I do try to counsel patients in the office how this exam is done. We can provide printed information. Sometimes patients ask when they should do this examination. For premenopausal women who are still having their menstrual cycle, often this is after the cycle when they're less tender and uncomfortable. For perimenopausal women or menopausal women who may not have the cycle to guide them, we'll give them a suggestion as to when to do it during the month. It might be the date of their birthday. For example, if their birthday was February 2nd, doing the exam the 2nd of every month, or if there is another important number that will remind them to do the exam. Women of average risk for future breast cancer should generally initiate annual screening mammography at the age of 40. There are some women as young as 25 who may need to be evaluated for their future potential risk, and this usually falls into the hands of the primary care physician or gynecologist that they're seeing, because there are some women younger than the age of 40 who may need to start screening earlier. Women who are higher than average risk of breast cancer may need supplemental imaging and may need to deviate from that standard age of 40 and may need to start screening earlier. And there are a number of reasons why a woman may be considered high risk. There is also the factor of breast density to consider, so women who have dense breast tissue may need supplemental imaging. They often do not need imaging earlier than the standard age of 40, but they may require a screening ultrasound along with their screening mammography. I think it's also important for women to know that 3D mammography, which is also called tomosynthesis, is something that's widely accepted as the standard of care these days. Previously, it was actually offered at additional cost. Not all insurance companies would cover it, but for the most part, it is standard of care, and most women should be undergoing screening, digital, 3D, or tomosynthesis mammography. Something I also wanted to stress is that patients without breast disease may need to see a breast specialist. So for example, patients with significant family history may be best cared for by a breast specialist in addition to their screening examinations. So if their primary care or their gynecologist doesn't suggest this, patients really need to be able to advocate for themselves to say, hey, I have a family history that's significant, should I be seeing a breast specialist? And if it's questionable or the provider doesn't know how to answer, it's simple. Refer them to a breast specialist, which is again, usually the breast surgeon. I have to say that at St. Joseph's Hospital where I practice, this is a really enjoyable part of my practice, getting to see these patients who may be nervous and anxious about their future breast cancer risk. Sometimes I can talk them off the ledge and they're not as high risk as they think they are. And sometimes they are high risk, and it's really important that they've come for this consultation. We will discuss ways in which they can be monitored more closely, if that's really necessary, the pros and cons of doing that additional testing. We can talk about genetics and whether or not genetic testing is something indicated for them. I will say that genetic testing is not mandatory, it's a personal decision, and we'll review that. So there are ways in which I can help patients who have no breast disease at all. The bottom line is I really feel that we need to focus on our mental health. We need to do things that psychologically or mentally nourish us, and that this contributes to our overall state of well-being. And to be truly healthy, you need both good physical health and good mental health.
Thank you, Dr. Mancuso, for the great advice. Coming up next, I'll be joined by a gynecologist who will let us know about the latest screenings and the one piece of advice she gives to each of her patients. You're watching Stronger Together with Dr. Dave. Welcome back to Catholic Health, Stronger Together with Dr. Dave. Today is our Women's Health Special, and now I'm joined by Dr. Laura Sheridan, a Catholic Health gynecologist at Good Samaritan University Hospital. Welcome, Dr. Sheridan.
Thank you.
This is a very important episode. I've been waiting for this episode for a long time, and we're going to speak to you about women's health, but from a gynecological perspective.
Great.
So let's start from the beginning. When should a female start to see a gynecologist?
It's a great question, and it does definitely come up often. So typically what I'll tell people is that routine screening begins at the age of 21. Typically not before then, but there are individual circumstances that may require a younger person to go to the gynecologist. And those things will kind of come to light earlier, but one of the most common reasons that younger people may need to come to the gynecologist a little sooner is if they're having a lot of trouble with their menstrual cycles. It's certainly something that you would want to take even a younger patient to the gynecologist for.
So you'll establish typically a relationship from the age of 21, and then how long does that relationship last typically?
The beauty of my job is it can last forever. We really go full circle, taking care of mom, we can be taking care of daughter, and even grandma. So, we start at the age of 21, and until you're 75, 80 years old, you can still be coming to the gynecologist for routine exams.
Do gynecologists feel comfortable being the gynecologist and the primary care physician, or do you also advise these patients to have a primary care physician?
Yeah, that's also a really great question. Usually at a certain age, which I would say is usually around 40, unless you have any other medical risk factors, by the age of 40, you definitely want to have a primary care physician on your side. And the reason for that is the things that a gynecologist does is a little bit limited in scope. And what I mean by that is we're typically focused on breast exams and pelvic exams. So you're not getting your heart checked, you're not getting your lungs checked, we're not doing routine blood work to check for cholesterol levels, which are going to become important in the later years. So you definitely want to have a primary care doctor who's going to be checking those other organs as well.
What are the guidelines advising today in 2024 in terms of when should a female start being screened for breast cancer? And then what is the appropriate screening modality? Is it a mammogram? Is it MRI?
Yeah. So basically, our college in obstetrics and gynecology, we recommend that all low-risk women begin screening at the age of 40. That screening typically involves a mammogram, sometimes a supplemental sonogram as well if the tissue tends to be dense or fibrocystic, or if you have a family history of breast cancer. And to that end, if you have a family history of breast cancer, we typically will start that screening at the age of 35 or 10 years prior to your affected family member. So the example is if your mom, let's say, was 42 years old when she was initially diagnosed with breast cancer, you really need to be starting your screening at 32. And that would typically be with a mammogram and a sonogram and even sometimes a supplemental yearly MRI of the breast as well. But the routine is a mammogram.
Gotcha. Okay, and in terms of gynecological cancers, I know that's a little trickier.
Yeah.
Ovarian cancer, uterine cancer, is there routine screening advised? When would you start thinking about that?
Sure. So, part of why you come to your gynecologist every year is to check in to see if there's any new things that have popped up over the last year of your life, changes in your menstrual cycle, things that may prompt us to do additional testing. Our imaging modality in the GYN world is a sonogram, a pelvic sonogram. That can check your uterus, it can check your tubes, and it can check your ovaries. Unfortunately, even as advanced as we've become in today's day and age with cancer screening, ovarian cancer is something we still very much struggle with. There is no routine ovarian cancer screening. There's no routine blood test, there's no routine sonogram, because you'll find incidental things on many sonograms that you do, and the majority of them are not going to be ovarian cancer, and then you're just kind of nervous about what to do with these results. If you have a family history of ovarian cancer, we will monitor you a little bit differently with these sonograms, sometimes with blood work, but nothing is very specific at this point to detect ovarian cancer, which is why it's typically diagnosed a little bit later than most would like.
So there are a lot of women watching this show right now.
Yeah.
What are the symptoms that they should be concerned about, and when should they call their gynecologist and get checked?
So any changes in your menstrual cycle, even if it doesn't seem like it's that off, if it veers from what your normal has been, it's worth the phone call. And definitely if you've gone through menopause where you've gone that 12 months without a menstrual cycle and now all of a sudden you start bleeding again, that's not normal. That would not be considered a period if you've been in menopause for 2 years and all of a sudden you start bleeding. That prompts an evaluation, typically with an exam and a sonogram in the office as well.
Okay, and since you mentioned it, menopause, this comes up in my world of cardiology all the time. I see patients and they're having vague symptoms and they assume they're in menopause.
Yeah.
What is the definition of being in menopause?
So traditionally speaking, again, without other risk factors, that you're very early in your 40s, that might make me think differently. But if you're, average age around 50, the average age is 51. So if you're around that age and the periods start to spread out a little bit and then you go 12 months without a bleed, typically at that point you would be in your menopausal state.
Is there a role for checking hormones?
So a lot of women will ask about getting their hormones checked. Once you're in menopause, there isn't a lot of utility in checking the hormone levels because we know certain levels are going to be high and estrogen is going to become undetectable. So I can already tell you that that's what the blood work is going to say. However, if we're not maybe sure if you're truly in menopause yet, that's where the hormone testing can become helpful because we expect a certain range with those numbers once we get the results back, and that will indicate that menopause is likely.
When should we start screening for osteoporosis?
So typically 65 has always been the preferred answer, but we do tend to start doing bone densities a little bit sooner. Once you're in menopause, we know that estrogen is going to go down, and that's a big factor in your bone health and creating strong bones. So once you're in menopause, that bone health is going to start to deteriorate. So once you've been in menopause for a couple of years, you should consider getting at least a baseline bone density scan. That's a DEXA scan, and a primary care doctor or your gynecologist can order that testing for you. And then based on those numbers, we'll decide if you need supplements or medication.
Fantastic. Anybody watching this program right now is going to have to record it because they need to watch it about 10 times with all the information you just gave us. This was unbelievable. Dr. Sheridan, thank you for joining us.
Welcome.
We're definitely going to have you come back, and we have a lot more to talk about in the future.
That's great.
Coming up next, we're going to learn the importance of a primary care physician on your care team. That's next on Stronger Together with Dr. Dave. Welcome back. My fourth and final guest on this Women's Health Special might be the most important. Dr. Sharesa Charles is a Catholic Health family medicine physician at the Family Care Center at Mercy Hospital. Dr. Charles, thank you for joining me today.
Thank you for having me.
This is an episode I've been waiting all year to do because as a practicing cardiologist, I see a big shift in medicine these days. And what I'm noticing, and I don't know if you agree, but medicine is becoming very unpersonal, depersonalized, because we have patients who are using urgent care centers and specialists, and there's no relationship with a primary care physician. What are your thoughts?
I absolutely agree with you. I think, unfortunately, you see kind of like urgent care centers popping up left and right, and patients definitely think that, oh, okay, I just go see a doctor at the urgent care, get whatever I need, and then I'm on my way. But it actually is shown to lead to worse health outcomes. You don't actually get to the bottom of what's going on with you. And that's part of why I did family medicine. I love to do that longitudinal care. I get to know my patients. I get to have a better idea of what's going on with them. And if you do have an issue, I get to see them in a week or in a month and get to follow up and figure out this is really what's going on with you and get to the bottom of their health condition.
How is the relationship different between a primary care physician and a specialist?
So I find that specialists tend to be more problem focused. You really kind of focus on a singular organ system. Whereas with family medicine or with primary care in general, the idea is to kind of look at your health as a whole. So we look at the context of your heart condition, but also how does that play with your kidney condition, or how does that play with your neurological conditions? And we kind of look at the picture as a whole. And our job is to kind of act as liaison. I talk with the cardiologist, I talk with the gastroenterologist, I find out what each is doing and to make sure that it really benefits the patient's overall goal for their health and where they want to see their health go.
Right, so you're really the quarterback and the advocate all wrapped up in one.
Yes.
And that's what I love about primary care, because I see so many patients, they have a urologist, a cardiologist, a neurologist, right? But they don't have a primary care physician.
Yes.
So nobody is talking to each other.
Yes.
So I can diagnose somebody with a heart condition and the urologist and the neurologist and the other urologist won't know about it. But the primary care physician can take all of these different specialists and synthesize it, right?
Absolutely.
And this is why people need primary care physicians.
Absolutely. I'm the home base. Come back to me and we'll help to coordinate everything.
I love it. And that's exactly right. What makes Catholic health different from other health systems?
First and foremost, I think it's just the welcoming environment of Catholic health. I'm a fairly new physician in this system, and I do find that once you walk in through the doors, everyone's super friendly, everyone's nice, everyone, hi, how are you? Welcome, have a seat, what can I do for you? And I really think when it comes to seeing your doctor, that's the biggest hurdle that patients have to get over. There's always that apprehension of coming in to be seen. Well, do they care? Am I, an individual person? Am I just a number to them? And that's definitely something that Catholic health does not do. You guys and I now, treat patients individually and meet them where they're at.
Catholic health to me is compassion. And I think that aligns with good medicine.
Absolutely.
Because if you treat people like they're your own family, you're going to give them really good care and good medicine. So tell me about Mercy's Family Care Center. What makes it different?
So Mercy's Family Care Center, it's a newly constructed state-of-the-art building that is located at the Mercy Hospital campus. And the goal of the center is to really carry out the legacy of the Sisters of the Congregations of the Infant Baby Jesus. And their goal is to serve the underserved, serve those in need, and to really be a central location where people can come for help. Traditionally, the center has been focused on women's health and pediatric health, but more recently they've expanded that to include family medicine, to include maternal fetal medicine, bariatric. It really is a center to give holistic care to the underserved and to address their complex healthcare needs.
So is it one center? Is it all under one roof?
It is all under one roof, to believe it or not. We have pediatrics in one wing, we have OBGYN in another, we have family medicine in another, bariatrics in another, and then certain days of the weeks we have pulmonology, cardiology for both peds and adults.
Wow.
So we have a lot in the center.
What are some of the principles that you yourself live by for a quote-unquote healthy lifestyle?
So that's a great question, and I think sometimes patients kind of get confused with all of the stuff that they see online, but really simple little things that you can do. The number one thing I try to do is try to get adequate sleep. I don't always get the 8 hours, but I try to make sure that it's restful. So I try to remove distractions. For me, the biggest thing is that phone screen time. I put it on the other side of the room. On iPhone, you have a little, it has a little wind down bedtime function to silence your calls. That helps me to get that adequate rest at night. The other part that I try to do is increase my activity. Any amount of activity is better than no activity. So whatever you do at baseline, just try to do a little bit more. Park further away in the parking lot. Go up the stairs instead of taking the elevator. And then the last part comes to the diet, kind of to your point earlier. Pick a vegetable that you can tolerate. Most of the time my patients tell me they don't like vegetables. Well, pick one, whether it's lettuce, it's broccoli, it's green beans, something. Put it for dinner, let's say, have it be half of your plate. Do that consistently and then see if you can add it to your other meals during the day.
It is so encouraging that here on Long Island, I hope this is happening throughout the nation, that the new model is holistic, compassion, and getting to know your patients.
Absolutely.
Thanks so much for joining us.
It's been a pleasure. Thank you for having me.
It was a pleasure. Thanks. Thank you to all of my guests for such a great show. As you learned today, there are some unique challenges women face with their healthcare needs, but hopefully we've given you the resources today to get the answers you need. If you would like to know more about Catholic health or to make a gift in support of one of the amazing programs you heard about today, please visit chsli.org or call 1-855-CHS-4500. Thank you for watching today. I am Dr. Dave Degatti, and I'll see you next time on Catholic Health Stronger Together with Dr. Dave.